Hey team, it's Doc Bryan. Let's talk about crush syndromes and crush injuries in EMS. Time versus damage, the evidence and the paradigms. All right, this is coming to you at your request, and I think it's a very reasonable thing to take a look at. So let's dive into it, have a little fun, try to keep it under 3 minutes as far as the actual content. And the lawyer time. I'm not your medical director. I'm not the state medical director. Nothing I say supersedes your medical director, your SOPs, your provider level or certification. All right, team. So when it comes to crush syndromes and crush injury, obviously this is going to be very basic, very foundational, and also it's to a group of subject matter experts. So I'm going to try to keep it pretty straightforward and short and simple, which is a crush injury is when you have a specific area of the body that's damaged via some type of crush injury pattern that causes ischemia and cell death. Versus a crush syndrome, which is when that crush injury is significant enough to cause systemic pathology or systemic problems, right? And that's important. When it comes to understanding as a pre-hospital provider, what does it mean? What do I care about crush syndrome, crush injuries? Well, it really comes down to time and the amount of damage. So in other words, how long have they been in a crush situation? What was their health going into it, right? And then how large is the injury and the syndrome, how significant. So how many cells are damaged and how long have they been ischemic, and then is this going to be an injury versus a syndrome. And our immediate concerns, of course, is our safety, typically in crush type scenarios, right? Our safety, the patient safety, how we can quickly reperfuse the patient, right? So they're not ischemic and less likely to have further ischemia, cell damage, loss of limb, and life. And then we think about the possible complications of the reperfusion, both with regards to safety in the field to them and us, and also with regards to once I reperfuse them, do I have to be concerned about crush syndrome, meaning in our case in the pre-hospital environment, right? Crush syndrome concerns we're talking about are life-threatening ones. So when we talk about crush syndrome, we're really talking about immediate cardiac impacts of a massive release of crushed cells, meaning potassium spikes rather rapidly, and can this impact the cardiac irritability and cause a lethal arrhythmia. That's really when I think about it, what I think about in the pre-hospital. Of course, as a physician, I also think about, second order, third order, fourth order impacts with regards to myoglobinemia and other concerns and renal failure. And we want to provide, again, just like trauma, we want to create physiologic reserve. So we do want to account for those things. But in our scenario, we really have to be concerned about safety, rapid extrication, rapid reperfusion, and then being ready to deal with those. And we do have a protocol for that. So of course, you're responsible for your protocol. The longer term things that people often get into when you get into the deep medical literature is really about kidney failure and limb and tissue loss, which for us, again, it doesn't really impact us because we're going to just stay safe, keep the patient safe, reperfuse as fast as possible, and be ready to deal with those complications. And those complications, again, really in the first order, first tier aspect of it are, other than safety, I mean, with regards to the actual physiologic syndrome component of crush, is really like a spike in potassium that can cause cardiac issues, right? So that's what we're concerned about. And just so we know, and again, I hate to do these kind of things, but again, this is an advanced class for an advanced team and advanced providers who ask for this. So I'm just going to say, with regards to our Pennsylvania protocols, the evidence does not support preemptive treatment. That is pretty presumptuous, I say, presumptuous of the ALS critical care aspect of it. I definitely do not recommend that in our special operations or operative medicine teams that go far forward into the field, especially if you have cardiac monitoring, which we typically have in Pennsylvania EMS. So like, what does that mean? What do you mean by that, Tim? Well, getting the safety, reperfusion, hydration, these are all critical. But like giving bicarbonate and giving calcium gluconate or chloride preemptively, right, really has mixed or limited or no evidence behind it. And actually, when you look at that and when you think about it critically, it really makes sense, right? So primo nocere, right? We always talk about how does what I do help? How does it harm? Let's first cause no further harm, right? So at the end of the day, right, if it's greater than 30 minutes and you think it's going to be an injury significant enough for a crush syndrome, right, per Pennsylvania protocols, then you can get into preemptive medication prophylaxis with sodium bicarbonate and calcium. But at the end of the day, right, what we typically do in reality is we want to be safe, work with our team to make sure that those that are extrication experts and those of us that are medical, that we work in parallel to give the best outcome, which would be, if you can, cardiac monitor, IV access, IV fluids. They talk about NS in this particular protocol, and the evidence not super great one way or the other with regards to fluid type between LR versus NS, but we'll give NS. We're going to keep them hydrated. Hopefully we increase those micro pressures so that we can kind of push back against the perfusion injuries. We also hydrate them up so that then they can urinate out the myoglobin. We also try to work towards, and we talk about metabolic acidosis, but again, that NS versus LR versus this bicarbonate. At the end of the day, these are all longer term, second, third, fourth order impacts. And for us, what we really are looking at is, do we have them on a cardiac monitor? Do we understand what we're looking for with regards to peak T wave, T-wave slurring, flip T wave, and then like moving towards a sine wave with regards to hyperkalemia, right? Because that's just a hyperkalemia type syndrome. And if we do understand that, and we're looking at a cardiac monitor with a strip before you release them, if that's a possibility, or immediate upon release, and then you're able to observe them, and you have a good IV for sure, or two, and you have those medications literally in your hand and ready to go, and you have that plan, that ergonomic plan where you're like, nope, team, this is what we're going to do, and you start to see cardiac irritability with PACs, PVCs, peak T waves, working towards that. Hey, this is looking like it wasn't irritable, now it is irritable. Most likely this is secondary to a syndrome, and I'm seeing some cardiac impacts. Now that would be a more evidence-based time to give calcium chloride, calcium gluconate with regards to membrane stabilization. Understanding that the calcium chloride and gluconate have a very short half-life with regards to stabilizing the cardiac membrane, right? And what you have to do at that time after you give that would then go make sure you're hydrating, make sure they're trying to urinate, move them, keep them on a cardiac monitor, move them towards higher echelon of care. And then perhaps at that point, you'd give sodium bicarbonate, which also stabilizes the membrane with regards to stabilizing and forcing potassium into the cells, transiently decreasing systemic potassium. So these are the thoughts. But again, in summary, for us, it's really about our safety, patient safety, work in parallel with our extrication team to make sure that they're on a cardiac monitor, know what we look for with regards to hyperkalemia and emergency crush syndrome, right? And then our PA protocols with regards to pre 30 minutes, after 30 minutes, and we're just going to work towards that common sense approach per your SOP, both at BEMS and with regards to the state, and understand that type of paradigm with regards to how strong the evidence is, don't want to hurt anyone, prima nocere, and harm versus help with our medications. That's how I would approach it in straight summary, which is absolute safety for self, for patients, moving parallel with my extrication teams, cardiac monitor, multiple IV sites, make sure they're protected from being yanked out when the person is extricated, IV fluids. Pain management is a huge one. You definitely want some significant pain management, and I would be prepared to calcium followed by bicarbonate if we have any signs of systemic crush syndrome with regards to specific cardiac manifestations of irritability, like starting to throw multiple PVCs that they weren't, starting to have a peak T wave, flip T wave, progressive PR prolongation, T wave prolongation into like a sine wave. All right, so that's the quick down and dirty summary. I'd be glad to talk about it in more detail with you. As usual, we got to talk about the lawyers. So I am not your medical director. I'm not giving medical advice. We're just two professionals having a discussion. And it's important that we note that, given this will be open content.